Well, as you know, ALL has a very high MRD negative response rate to CAR T-cell therapy. So it doesn't matter the type of the design of the CAR T-cell, if it's industry or academic CAR T-cell, adult or pediatric population, 4-1BB or CD28, they all have very high response rate. The problem is that many patients still relapse. So so far, most of the studies focus on the impact of the drug, of the CAR T-cell in the safety and efficacy of the therapy, but somehow they haven't been focusing on what happens before CAR T-cell therapy, how we bring the patients to the therapy. So we already know that the amount of disease and the kinetics of the disease before cellular therapy is very important for allogeneic stem cell transplant, but this hasn't been very well characterized for CAR T-cell. So we have been analyzed which is the impact of salvage and bridging therapy. So salvage therapy will be all the therapies that we give the patient once it relapses before apheresis, so to take the patient to apheresis, and bridging therapy is all the therapy that we give from apheresis to CAR T-cell infusion to allow the patient to arrive to a CAR T-cell infusion. And what we saw is that, of course, the tumor burden, it's important, but we haven't seen really, by doing an intention to treat analysis, really a big impact of tumor burden in the overall survival seen from apheresis and from CAR T-cell infusion. But what we saw is that the most dramatic difference is not so much the amount of disease, but how the disease responds to salvage and chemotherapy. So it's how this salvage and bridging therapy breaks the proliferative kinetics of the disease rather than the tumor burden. So we have been comparing a lot of different types of salvage and chemo, of salvage and bridging therapy, as for high intensity chemo, low intensity chemo, inotuzumab-based, blinatumomab-based, or others, and we saw that, of course, the higher the intensity that you give, usually is the higher the response rate, but this response rate drops very significantly from salvage to bridging therapy. So we really need to choose very carefully which therapy we're going to be as a bridging, because how this will impact on the proliferative kinetics of the disease will have a dramatic impact in the efficacy of the CAR T-cell afterwards.